All right, so we'll get started with our second lecture here. This is going to be on heat-related injuries. This one won't take as long as the first one, fortunately. Again, no disclosures. We'll go through kind of a discussion about just normal thermal regulation and where those failures ultimately lead to the various types of heat-related illnesses that we're going to talk about. We'll talk about them more as opposed to like individual, distinct, or unique disease states. We'll talk about them more kind of in the context of a spectrum of types of symptoms. We'll look at risk factors predisposing patients for heat-related injury, as well as examine the evidence for what is optimal treatment as well as prevention. So we'll start out with a case here. This is a call that isn't going to be uncommon here in the coming months. EMS is called for someone who's found down after sort of wandering aimlessly in their neighborhoods, an elderly gentleman. On your initial assessment, he is arousable, is able to answer some very simple questions appropriately, but ultimately still demonstrates some amount of confusion. Let's call him a GCS, give or take. Is able to move all extremities, no focal defects whatsoever, very dry, warm skin. He's tacky, he's, hyperthermic and borderline hypoxic. So on your initial assessment with this sort of scenario, what would be some other key pieces of information you would want to know right away, things you'd either ask bystanders, family, or the patients? Blood sugar, yeah, so he's got a normal blood sugar. So if he's hypoglycemic, these definitely can appear to be some sort of symptoms. But his blood glucose, he's a non-diabetic. He's got a glucose of 85. What do you got? Does he know his address? He's giving you some information. He's like, that's where I live right there. And you're going to take that at face value. Anything else? What about past medical history? What medications he might be on? And in the context of this lecture, what's the temp outside? What does this guy otherwise look like? So, he's going to tell you, or someone else is going to tell you, it's hot. This is what the weatherman's going to be saying here for the next 4.5 months. And as Bobby Hill showed us, 111 degrees in Phoenix, can it really be that hot? Oh my God, it's like standing on the sun. Duh, right? We're all familiar with that. The city shouldn't exist. It's a monument to man's arrogance. That's all fine and good. Everyone likes to take the piss at, Phoenix weather and such. I love it here. I don't mind the dry heat. But certainly we are at risk specifically and uniquely more so than in other parts of the country for heat-related injuries, specifically because of this Sonoran Desert region that we have that almost consistently above any other portion of the country, and specifically within the Southwest, where we will see dramatically higher temperatures than any other part of the country. And as we look to see what that actually means or equates to in terms of what that has as an effect on heat-related injuries, we can see that 2023, unfortunately, was another record year for heat-related deaths in Maricopa County. This was just put out last month as their 2023 summary on heat-related injuries that had some pretty stark statistics. And you can see that there's a pretty consistent increase in the number of heat-related fatalities. Part of this, our population's growing, but the other part is unstable housing. And so this tends to track almost uniformly with the more undomiciled patients that live in a particular area, and not just in Maricopa County, but in other areas that have heat-related injuries as well. Maricopa County makes this distinction of heat-caused versus heat-contributed deaths. Heat-caused deaths means that death was directly attributed to hyperthermia from some environmental or other heat-related exposure, whereas heat-contributed exacerbated some sort of underlying condition, but the heat was not directly responsible for that fatal outcome. Now, the distinction between the two might seem completely semantics, but for the purposes of data collection, epidemiologic survey, it does make a difference because there are very specific risk factors that heat could induce a fatal outcome in someone in whom that wouldn't occur without those risk factors. Unfortunately, this is a very poorly labeled slide, but essentially what this is showing us is the percentage of deaths year over year on days that are considered heat risk extreme, which the National Weather Service defines as temperatures over 90 degrees for more than 3 days. Now, for us, that's basically like May until September. So we've got like 120 of those days. Ours is a little bit different in terms of how the National Weather Service defines it, but you can definitely see in 2023, 3 out of 4 fatalities occurred on days where there was some heat-related advisory. And that kind of would be intuitive, and we see it in the data as well. There was a 2-week stretch here in July. I think it was like July 14th to the 27th or something like that, where every single day was above, I want to say it was like 105 degrees Fahrenheit, give or take, and about 303 of the 645 deaths attributed to heat-related injuries occurred just in that 2-week stretch. So we know we're coming up on the season where heat-related injuries are going to be quite significant. And if we look at who's most at risk, it seems to be those, again, with without stable housing or without any housing of any sort, those who live by themselves, really comprise the vast majority of people. There's a lot of different psychosocial, economic issues that play into these numbers as well. But again, just kind of highlighting from a residential or lack thereof standpoint, who's primarily at risk. And then when we look at gender and age, it definitely skews very heavily towards males as well as advanced age. We know that kids are certainly susceptible to some extent to heat-related injuries, but it definitely seems to be males above 50 that comprise the primary demographic of those that end up with heat-related deaths. And the reason this is important, not only because of the timeliness of where we are now relative to the warmest months of the summer coming up, is that this is 100%, well, nearly 100% preventable. So just kind of talking about basic physiology of thermal regulation, this is the mechanisms by which either we undertake behaviorally or that occur autonomically for the purposes of generating or dissipating heat, depending on what the environment is and what's going on. And we have a number of different ways we can do this. There's conductive, convective, radiant, and evaporative methods of heat gain, heat loss, as well as some autonomic mechanisms, sweating, vasoconstriction, and shivering. So again, some of these behavioral aspects, we might put on a jacket when we're indoors. We might move indoors into a cooler or warmer weather environment. Even outdoors, when it's plus 100, we'll feel that relief just by going into the shade or if there's a nice breeze that day. So there's a lot of these behavioral or environmental factors that play into heat dissipation or heat generation, as well as autonomic function. So again, sweating, vasodilation or constriction, piloerection, shivering, and then non-shivering thermogenesis. And we know shivering as a mechanism that the body through neuromuscular agitation can be used to generate heat. Non-shivering thermogenesis occurs through the activation of beta-3 cells in adipose tissue to generate heat. Not nearly as effective. This will probably be something from a pharmaceutical standpoint that'll probably eventually make its way into the market, probably in the next 10 to 20 years, probably for weight loss, but just so you're aware of that. But it's really some interruption in one or both of either the behavioral and or autonomic thermoregulatory effects that leads us into discussion of heat-related injury. So on the spectrum, on this continuum, we can see patients with discrete presenting symptoms as listed on here, but we really ought to think of heat-related injuries as something that occurs on the spectrum. And certainly more we move towards heat syncope, exhaustion, and stroke, we really ought to think of them as having gray areas of overlap between them. So we'll start off with heat rash. Heat rash cramps, these are relatively benign type symptoms. This is actually an inflammatory reaction that can happen when someone is sweating. This doesn't necessarily have to occur as a direct consequence of heat necessarily, but essentially they have blocked or clogged sweat glands either by bacteria or dead skin cells that causes retention of sweat subcutaneously that induces this inflammatory response. And a lot of times these patients have a concomitant skin infection, which is causing blockade of those sweat glands. This is usually very mild. It can be a little uncomfortable. The symptoms can definitely persist. But apart from just very supportive care, maybe topical steroids or aspirin to help control some of these symptoms, this is definitely not really anything sort of consequential and something unlikely that you are going to ever have to manage specifically. We can also see heat edema. This is just third spacing of fluid as a response to peripheral vasodilation in response to a hyperthermic environment. So the treatment would be removing that patient from whatever the heat source is, elevating the limbs, and no diuretics. This is not a scenario of excess fluid. It's just fluid that's redistributed out of the vasculature and into the interstitial space. Heat cramps, we probably see this on TV every now and again. This is a consequence of heat exposure with either inadequate hydration or just an overt loss of hydration and electrolyte, specifically sodium loss. And we think ultimately that cramps, these really painful, transient, and these could be leg, abdominal, arm cramps, are mediated specifically by calcium that seems to be in higher concentration, specifically because of the fluid and sodium loss. So again, most of these patients, just supportive care, removing them from whatever the heatful, stressful environment is, getting them some rest, hydrating them, giving them some electrolytes, whether enterally or parenterally is really the management here. But moving into heat syncope, now maybe we're getting some more significant symptoms. That said, heat syncope is one of those scenarios that even if it does occur, ought to be very short-lived. And this could be some form, and it doesn't always have to be full loss of consciousness. It could be someone who feels pre-syncopal, dizzy, but doesn't necessarily have to have a full syncopal episode. And again, kind of like the heat edema, we have vasodilation with peripheral pooling of blood, taking it away from the core, the heart, lungs, brain, causing this very transient, sudden loss of consciousness or change in mental status. But these patients tend to, with, again, this supportive care, recover very, very rapidly, usually within seconds to minutes. If the recovery requires much longer than that essentially expected brief period of time, other etiologies or comorbidities like cardiac disease really ought to be considered, and maybe a little bit either closer evaluation or a workup by the emergency department might be necessary. But again, moving from syncope into, again, what can be this spectrum. Let's say we've got this patient who appears like they've lost some consciousness, but then they've regained it, they're fine, but don't seem to really, kind of coming back to their normal state of mentation. Again, whether it's, because of comorbidities or not, now we're starting to move into the spectrum of heat exhaustion and heat stroke. And so again, we kind of want to think of these different disease states, again, not as, isolated, distinct entities, but, somewhere on the spectrum where you can relatively easily move from one into the next more severe category. And so some of the risk factors that we have for developing or moving into that continuum of more significant disease, we've got environmental risk factors. Oftentimes, these are also either occupationally induced, socioeconomically induced, or what have you, but you don't have the ability to take adequate breaks, get shelter, shade, hydration, typically working outdoors, high temps, high humidity. There are individual risk factors, age, extremes, so the very young, the very old, male, as we've already identified, those without housing, obesity, those who are unfamiliar. How many times do we hear the story, someone getting plucked off of PS to a Peak by one of the choppers because they came from the Midwest and decided to hike on a nice August day. Pregnancy and medications as well become important risk factors for susceptibility to heat-related illness. And then comorbidities, it's kind of a laundry list, but if we distill this down into major organ systems, it kind of makes sense. Those with pulmonary or respiratory disease, cardiac disease, those with diabetes. There are some relatively rare skin disorders that can, like if you don't have the ability to produce sweat because of anhydrosis, then you don't have the ability to dissipate heat through evaporative mechanisms, as well as those without anhydrosis. But generally speaking, diabetes, pulmonary, and cardiac disease are the sort of top three comorbidities that predispose patients to heat-related illness. And then there's a whole litany of medications that can contribute to either altered autonomic thermoregulation or behavioral changes that make that patient perhaps less aware of those hyperthermic conditions. And as we move into the summer months, we see these in conjunction with hyperthermia very frequently. If we think back to the toxidromes, stimulants, so methamphetamine, amphetamine fits into that stimulant toxidrome where the drug itself is going to cause hyperthermia. The vasoconstriction induced by those drugs is going to inhibit heat dissipation, which generally occurs because of vasodilation. And then alcohol as well, not necessarily because of an inability to dissipate heat, because alcohol typically will produce vasodilation. It's just that altered sensorium mitigates that patient's ability to kind of understand their hyperthermic environment. But there's, a whole host of different drugs here: beta blockers, calcium channel blockers, diuretics, antipsychotics, SSRIs, lithium, weight loss supplements. So, understanding a patient's medication history, past medical history as well, can help sort of contextualize exactly the, severity of the types of symptoms that patient might be manifesting, and certainly occupational exposures as well. I made this joke yesterday. I'll see if I can say it a little bit better. When I was doing Google search for like sweaty construction worker, I got very different types of results from Google. So I've basically had to erase my browser history. My wife was a little concerned when she hopped on the laptop. I did get this image from the initial search results. So it was really interesting that that top right image showed up with a lot of the other ones. I didn't think the other ones were that appropriate. But nevertheless, if you're outdoors, firefighters, you're wearing your Nomex, you're in front of fires constantly, or approaching hot situations, field workers, athletes, military personnel. These are just known scenarios, occupational scenarios where just overexposure to heat is a relatively commonplace phenomenon. So moving from heat syncope into heat exhaustion. So the beginning of where we consider these heat-related injuries to be potentially life-threatening. So we can also call this heat prostration or heat collapse. This is typically not necessarily a hyperthermic or febrile individual, but they're definitely symptomatic because of some altered, usually autonomic, if not behavioral, failure of thermal regulation. What really defines heat exhaustion and separates it from heat stroke is that these patients will almost always have normal mentation, but they'll have this profound fatigue, weakness, hypotension, nausea, vomiting, dizziness, headache, and they still can have diaphoretic but cool, clammy skin. And again, that becomes another differentiator of this end of the spectrum versus those patients who progress from this into heat stroke. And this is oftentimes not only just heat-derived or heat-caused, but also in conjunction with prolonged or severe exposure with dehydration and electrolyte loss as well. And so, we kind of see this kind of across the spectrum, whether occupational or someone literally like this guy who's out in the middle of the summertime doing some exertional activity, becoming dehydrated, having prolonged exposure, and developing that profound weakness. So the treatment here, pretty intuitive. You're going to remove the person from that heat source. We're going to apply some cooling technique. It really can be anything we want. It could be dousing them with water, using ice packs, cool towel, placing them in a supine position. hydrating them to whatever extent is necessary, maybe electrolyte replacement as well, but monitoring them to ensure that they return to whatever reasonable function and strength they had at baseline. And again, we're not necessarily expecting these patients who have normal mentation to return to a baseline because they should already be there. It's if they progress into having any altered sensorium that this patient crosses over from exhaustion into stroke. So let's revisit our case here. This is our patient, 71, so male. I didn't tell you that he was or wasn't obese, but it's pretty hot out, a lot of humidity, lives in an apartment by himself, no air conditioning. So we've got environmental, we've got comorbid disease states, we've got individual disease states. Here are his meds. He's got medication risk factors. So there's a lot going on with this individual that is pretty classic to understand. This is likely maybe multifactorial, but certainly what we would likely consider a classic heat stroke type scenario. So we do classify heat stroke into one of two different categories. We call them classic or exertional. And that's because there's two different demographics of patients oftentimes susceptible to the various heat stroke cases. So classic is what we tend to see more in clusters of patients, more concentrated during the summertime or during the hottest parts of the year. Oftentimes, it's the heat contribution to exacerbate those underlying comorbidities that leads to poor outcomes in these patients, whether by medication, functional ability, social or residential ability. They either don't have access to cooling or changing their environment to move from whatever that hyperthermic environment was. And again, this tends to deal with just a poor heat dissipation mechanism based on any of those risk factors that we went through earlier. And we differentiate classic, which again, is sort of episodic within a specific time frame, to the more sporadic exertional. This is that scenario, someone, football team, soccer team, what have you, is out playing a game in the middle of the summer, daytime, usually healthy individuals, but because of the prolonged excessive heat exposure, the resultant dehydration, electrolyte loss puts them at risk for heat stroke. So typically in this case, it's not a lack of, these autonomic thermal regulation mechanisms, that's what I'm looking for, that we have. It's really just that those mechanisms are overwhelmed by, again, that excessive prolonged heat exposure. And so we're really sort of underpins what heat stroke is this relatively complex derangement within numerous cellular and systemic systems. So generally speaking, we have failure of thermal regulation, again, whether behavioral or autonomic. We have this subsequent endotoxin response with a sort of terminal immune protein response that triggers a systemic inflammatory response syndrome that ends up resulting in multi-organ system failure. And we kind of see it in these three phases: the initial sort of 24 hours where they're primarily neurologically no longer intact, moving into day 2, 3, where we start to see the coagulopathy. And then beyond, day 3, 4, we're typically seeing the multi-organ system dysfunction. And so if we go to the chart here on the right, we essentially see that, this heat strain, it's excessive exposure to prolonged excessive heat causes sort of two parallel processes. And there's a point after like 106, 107, 108 Fahrenheit where that heat is directly cytotoxic. It disrupts multiple biologic processes, causes many proteins in our body to dissociate or just break down. So we are essentially melting, for lack of a better term, from the inside out as a direct cytotoxic effect of the heat. But we also have this really interesting phenomenon that happens within our gut. So the hotter we get, the more we try to autonomically compensate and dissipate that heat. So what we'll do is we'll vasodilate the periphery at the cost of vasoconstricting our core blood flow. And what that eventually does, if it's long enough, persistent enough, we can get hypoperfusion of the gut, which causes an alteration in the membrane permeability of the otherwise intact gut. And it causes this leakage of these endotoxins that normally stay within the GI tract, and they translocate into the central vasculature, inducing this endotoxin-mediated immune response. This, in conjunction with the direct heat-related cytotoxicity, stimulates that SIRS reaction that then progresses that patient onto multi-organ system failure. So it's relatively complex, but it's quite easy, I guess, intuitively, just to understand you're just kind of cooking from the inside out because of that hyperthermic environment. So what are the initial symptoms and how do we differentiate heat stroke from heat exhaustion? And where we said in heat exhaustion, kind of the two big differentiators were change in mental status and the sort of skin diaphoresis versus dry. These patients are almost always altered and have very dry, warm skin. And this can progress quite rapidly from not insignificant symptoms, but definitely into life-threatening effects quite rapidly. So it's that early recognition, that early assessment that heat could be contributing to the clinical effects of this patient is very essential to get them rapidly treated so you can have a good outcome. But again, also understanding what risk factors play into that patient's presentation, how long they've been that way, whether it's exertional, how long they were out doing whatever activity, were they hydrating, things like that. What's the relative environment? Are they able to move from warmer to cooler weathers? Disease states, medications that are all playing a role here. And again, the reason this becomes important is because this is a life-threatening reaction to heat. And so with classic heat stroke, we can see mortality rates exceeding 50%. Less with exertional, but depending on the severity of exertional heat stroke, we can see mortality rates in about 1 in 3 patients. Even in your otherwise healthy younger adults, we can still see relatively high mortality rates. And we know that those mortality rates, or the ability to avoid that, directly relates or correlates with the magnitude, duration of hyperthermia, and how quickly we can identify and cool that patient. So really early recognition, rapid cooling is the foundation of how we're going to manage these patients. So just like with the other disease states, we want to ensure that we can remove them from whatever the hyperthermic environment is. We are always going to focus on ABCs first. These patients can get unstable quickly. So ABCs essential first, but if you've got that otherwise stable patient, we do want cooling to at least be initiated before transport to a healthcare facility. We don't want to put that on the ER staff. That needs to be initiated out in the field. And we can do that a lot of different ways: cold water immersion, cold water spray. We can do, wet towels, ice packs, things like that. Rehydration, depending on the temp of the IV fluid you're giving and the rate at which you're giving it, might have some impact. Generally speaking, parenteral fluids are not really the way to cool the body. So it's not really going to be the primary driver of getting that patient back to a normal temp. It's really going to be this external cooling that we're going to be able to provide that makes all the difference in their overall outcome. Do antipyretics work? Is there any role for ibuprofen or acetaminophen? Absolutely not. And that's because the multi-organ system failure, essentially the anticipated organ failure that is anticipated, essentially puts that patient at a higher rate of drug-related toxicity. So you're just kind of compounding the clinical effects that we're going to see here. So what is ultimately the best way to cool these patients? We have a lot of different ways that we just kind of quickly went over, but we know that cold water immersion beats every other modality. Maybe not always the easiest to perform, especially in the field or in the back of a rig, but it is the standard of care to most rapidly and efficiently cool these patients. We don't need to make them hypothermic. We really are just shooting for a goal temp of about 38 to 39 C within the first 30 minutes. And it has the strongest level of evidence and the highest quality that exists. And if we go by the numbers comparing the various techniques, cold water immersion up here, we can see that it produces the largest change in temperature over time relative to all the others. It's most effective in healthy volunteers. That's obviously not who we're treating. There are still some compensatory mechanisms of, thermal regulation failure in our heat stroke patients where we see this slightly diminished cooling effect for cold water immersion in the symptomatic patient versus the healthy volunteer. But the rest of these are all in heat stroke patients. And we can see that, again, the degree to which we can influence core temperature with these various cooling techniques means that ultimately cold water immersion is our best option. So how can we do it? There's, certainly different ways for sure. Everyone's got their own setup usually, but if you need to do this out in the field and you have access to a body bag and a bucket of ice and some water, all you need to do is, insert a patient and just kind of let them cool. Hopefully you've got a temp sensing rectal or Foley that you can use so that you don't overshoot them. But again, if you don't have access to cold water immersion, then using some of the other techniques described becomes the next best thing you can do until you can deliver this patient, to an appropriate healthcare facility. There is the concern sometimes, at least anecdotally or intuitively, that someone's going to say, well, I do the ice dunking right now and I start to shiver. What about shivering in these patients, or what about the intolerance generally? Well, we actually tend not to see shivering that much. These patients are so profoundly hyperthermic and or altered that shivering just doesn't become a barrier to initiating this treatment. The less altered you are, or the less hyperthermic, perhaps shivering, or certainly if you overshoot, you cool them below 38°C, we can see some shivering, but we can manage that pharmacologically, benzodiazepines, and that can help cover some of the agitation intolerance as well that we might see in these patients. But if they're intolerant or you don't have access to cold water immersion, putting ice packs in the groin and the axilla, using evaporative cooling with a fan and a wet body. We used to, in Fresno, when we saw these patients in August, because this data showed up after I was in my training, we would just get a couple of towels, soak them down, strip the patient down, put them on the stretcher in the trauma room, cover them with a couple, 2-3 wet towels, and get 2-3 fans blowing across them. And holy smokes, do they cool relatively rapidly. Not within 30 minutes like cold water immersion, but nevertheless, you have other modalities. Something's better than nothing, but as best as is possible, cold water immersion is going to be that gold standard. So just kind of in summary here, this is ultimately, a highly preventable injury. Certainly there's circumstances, risk factors outside of our control that we're going to be able to manage for that patient, but certainly recognition on our end, at least initially during that assessment, can help sort of contextualize the seriousness or gravity of the situation. So early rapid recognition, differentiation of where they are in the spectrum of that heat-related illness, what risk factors, comorbidities as such are contributing to that, and how quickly we can initiate adequate cooling. Again, cold water immersion is our gold standard, but we have alternatives based on logistical or patient intolerance. And there really is no effective pharmacologic treatment. There are adjuncts we can give, like the benzodiazepines for shivering, for agitation, things like that. But there really is no drug-related therapy we can provide that's going to alter thermal regulation any more efficiently than cold water immersion. So I will conclude there. I'll stick around if there's any questions. I know we've got another talker here in like less than a minute. So thanks very much for your attention.